President of the jury, Doctor of Health Sciences Angelina Kaleta-Pilarska, Professor Wojciech Pluskiewicz, and Doctor of Medical Sciences Elżbieta Tabor. I will now explain the rules of the session. The order of the presentations will be the same as in the jury assessment sheets. The maximum time for the presentation is 7 minutes and 3 minutes for the discussion. If the presenter exceeds the time, they will be asked to move on to the conclusions and end and finish the presentation as soon as possible. Esteemed jury, I would like to kindly remind you that if you are the supervisor of a paper which is being presented, you should not assess the work. In that case, please cross out the number on your card. Other members of the same clinic are able to assess the presentation. The assessment will be verified. I would like to remind that if the work is presented in English, the discussion also should be run in English. If the commission asks a question in Polish, the authors of the work are obliged to answer in English. We kindly ask the jury to assess the scientific value, the way of presenting, the discussion, and own creative contribution in a scale of 1 to 5 points. When the session ends, we kindly ask you to give the cards back to the coordinator. With all that out of the way, we can begin our session with the first presentation. I would like to ask to present the paper entitled Sharper Than Human Eyes, a meta-analysis of artificial intelligence for retinal detachment detection by Paweł Łajczak.
My name is Paweł Łajczak, and I am a student of the scientific loop at the Department of Ophthalmology. And today I have prepared a systematic review and diagnostic meta-analysis on the retinal detachment detection through the artificial intelligence. So what is retinal detachment? Retinal detachment is a serious condition when a retina peels off of its supplementary layer. While the incidence rate is only 1 per 10,000, a serious visual impairment can occur. Sudden vision changes such as flashes of light, floaters, and blurred are common symptoms. Diagnostic modalities include ultrasonography, OCT, or the fundus imaging. A novel technology called artificial intelligence has already been applied in the various fields of the medicine and the ophthalmology, including diagnosis of the diabetic retinopathy, papilledema, retinoblastoma, coloboma, glaucoma, or cataract, as well as the management of the surgeries with the artificial intelligence. According to the PRISMA guidelines for reporting systematic reviews and meta-analysis, we have conducted a systematic search across various databases to find over 20 eligible papers reporting diagnosis of the retinal detachment. Most of our studies, because over 14 out of 20 were from People's Republic of China. 17 out of 20 papers reported use of deep learning techniques. 3 of them used classic machine learning techniques, included support vector machines. Most of our imaging modalities were reported as fundus imaging. However, ultrasound and OCT imaging was also reported. We found, unfortunately, major bias in the patient selection criteria according to the quality in diagnostic accuracy risk of bias tool, mainly because of the lack of clear inclusion criteria and also in clear criteria on the reference standard. Here is summary of our studies. As you can see, most of the studies had concern in patient selection criteria. The pooled sensitivity from over 60 models was 96%. And specificity was 99%, resulting in a very good discrimination of negative instances. However, notable heterogeneity was observed, 95% in the sensitivity analysis and 97.7% in the specificity analysis. Additionally, we have analyzed the heterogeneity through the MIDAS software, which is a package to the status software, and we found out that 10% of the heterogeneity effect was caused by the threshold value, so we can suspect the differences between the methodology of the studies. Then we have conducted a bivariate analysis of the included studies, and we found out the area under curve through the pooled 20 studies was over 1. Additionally, we have conducted a additional area under the curve analysis from the studies which solely reported this value, and we found out that this area under curve was 0.98. Unfortunately, our analysis was found to be with the publication bias. We have explored bias among the studies through the Dix plot, and the significant bias was present. We have also explored outliers among the studies, and most outliers were found to be ultrasound images, through the ultrasound imaging. And here's the box plot to visualize the outliers among our analyses. We have also performed a subgroup analysis to further explore the performance of algorithms related to the diagnosis of retinal detachment. According to the classification to the artificial intelligence, deep learning methods showed superiority to the standard machine learning algorithms. In terms of validation, the cross-fault validation and speed validation were relatively similar in the model testing. They showed similar sensitivity and specificity. Finally, algorithms tested on the greater testing set size showed superior performance to the algorithms tested on the smaller test size. This analysis proves that artificial intelligence can be a useful tool into accurate diagnosis of the retinal detachment, showing promising values in terms of sensitivity and specificity. Furthermore, included studies showed flexibility in the diagnosis of retinal detachment from the OCT, fundus, and the ultrasound. The potential future includes the probably development of even more advanced algorithms, which should cover especially the OCT and ultrasound. Unfortunately, our systematic review and the diagnostic meta-analysis is not without any limits. First of all, the observed heterogeneity among the methodology of the studies was observed. Additionally, there weren't reported that many OCT and ultrasound images, as most of the imaging modalities included over 12 studies reporting fundus imaging. Additionally, our analysis did not perform a cost-effectiveness analysis, which should be valuable for the clinical implementation in the future practice. Thank you very much.
Thank you very much for the presentation. Now, if anybody has any questions, if the jury has any questions, now is the time to ask them. Okay, if nobody has any questions, I will ask a question. What is your own contribution in the work?
I have conducted, this was actually my idea, and I have conducted a systematic survey analysis.
Okay, I believe that's all. Thank you very much for the presentation. And now I would like to ask for the next participant to present the presentation entitled Global Perspectives on Atopic Dermatitis, Clinical Phenotypes and Immune Responses Among Diverse Populations by Joanna Zagadło, who is with us online.
Hello. I am able to connect the presentation to Zoom, or you will add it?
You have to share your screen and connect the presentation.
Okay. Just a moment. I think that sharing screen is switched off.
You cannot share your screen?
Mm-hmm. Yes, I think the function is switched off because I can see it. Okay, now it's on. Okay.
Okay, we can see your screen. We would like to ask if you can put it in full screen mode. So
yeah, I'm trying to. Okay, is it okay because I can't hide the thing on the side?
If that's all you can do, then you can start.
Or wait a second. Okay, so I will start in this. So good morning, everyone, honorable jury and dear audience. Today I'm going to talk about global perspectives on atopic dermatitis, clinical phenotypes, and immune responses among diverse populations. Atopic dermatitis is a very prevalent chronic and immune-mediated skin condition. Itchy dermatose lesions, mostly in flexural areas, are common, but there is significant variability in symptoms across different ethnic groups. Nevertheless, Caucasian patients are the most studied group, which often leads to disparities in diagnosis and treatment. Our study aimed at understanding the clinical, genetic, immune, and treatment response variations in atopic dermatitis across diverse ethnic groups to improve patient care worldwide. We conducted a systematic review using databases such as PubMed, Embase, Scopus, Medline, Web of Science, and Google Scholar. The search focused on terms in medical subject headings that were ethnic differences, or racial or ethnic or minority groups, and atopic dermatitis or eczema, with last search in December 2023. Eventually, we included 51 studies that addressed selection criteria, excluding case reports and incomplete data studies. So starting with visible clinical features, they vary. While Asian patients show more psoriasis-like plaques, lesions were defined borders with increased scaling and lichenification, African patients often have more extensor involvement and perifollicular accentuation. Also, lichen-like presentation and post-inflammatory pigmentary changes are statistically more prevalent in this group. In darker skin types, it is often a challenge to diagnose atopic dermatitis properly. Erythema is often absent, and diagnosis can't be made using simple Hanifin and Reika diagnosis criteria. It may rely on edema, warmth, and scale. Also, clinical scoring systems to evaluate the severity tend to underestimate severity in darkened skin due to less noticeable erythema. Statistically, more frequent are features like xerosis, hypergranularity of palms, and Denny-Morgan lines. Genetic differences are notable. While filaggrin gene is always considered to be the strongest genetic risk factor for atopic dermatitis and associated with severe atopic dermatitis symptoms and increased risk of infections and allergic sensitization, loss of function mutations are prevalent in 50% of Europeans and 27% of Asian patients. But they are totally absent in Africans, even though they have decreased filaggrin levels. Different gene mutations are present in African patients. So in Ethiopians and African Americans, which is the most studied African group, filaggrin 2 and Claudin 1 mutations are more common than in other populations. Current immune response also varies by ethnicity. While Th2 and Th22 response is prevalent in all populations, Th17 and Th1, the psoriasis-like response, is the most prevalent in Asians and totally absent in Black ethnicities. It indicates different immunologic background and potentially different treatment response in this group. Current treatment guidelines do not differentiate by ethnicity, yet our findings suggest variations in efficacy and side effects, indicating a need for personalized treatment plans. Topical treatment, like steroids, are similarly effective across ethnicities, while they can cause more hypopigmentation in darkened skin types. Narrow-banded UVB and cyclosporin needs more doses in darkened skin types, while methotrexate and azathioprine can cause more toxicity due to enzyme deficiency in Black patients, which indicates the need to profile the doses to these patients. Biologic treatment is comparable in few studies, very few studies that compare this between ethnicities, and they are concerning dupilumab and tralokinumab. To conclude, despite advancements, significant gaps remain in understanding how different ethnic groups respond to atopic dermatitis treatment, underscoring the need for future research. And this research highlights the importance of considering ethnic-specific clinical features and genetics in managing atopic dermatitis, which include geographic bias, database limitations, potential publication bias, and quality variability. And here is the full list of references as the publication about this topic is being prepared. Thank you for your attention.
Thank you very much for the presentation. Now we will move on to the discussion. Are there any questions in the audience or in the jury?
Czy dotarła Pani do jakichś polskich badań, jak to wygląda w naszym kraju, jeśli chodzi o temat, który Pani poruszała?
Okay. You mean about ethnic differences or the genetic variability and immune response? Because if it's about the ethnic differences in Polish populations, there are no studies. Like our population is quite similar, but there are few studies about about genetic background in our population, and we are just like other Caucasians. Filaggrin gene is estimated to be about 50% in our population. And Th2 and 22 response is the most prevalent one.
Are there any other questions? If there are no other questions, we thank you very much.
Thank you.
Now I would like to ask the next presenter to present the paper entitled Metformin Therapy in Patients with Acne Vulgaris, Meta-analyses by Weronika Szczybiak-Skora.
Okay, so I upload my presentation. I don't know if it's seen. So can I start?
Just a moment. Could you put your presentation in full screen?
Yes, I've just do it.
You can also click F5 on your keyboard.
I'm sorry, I didn't hear you.
You can click the F5 button on your keyboard.
F5, okay. Now?
Could you try sharing your screen on Zoom instead of the application?
Oh, it could be. Maybe I try again. Okay. Okay, so I try, but something goes wrong. Now it's okay?
Yes, if you could click the PowerPoint, now F5, it should be perfect.
Okay, so can I just a minute, because it's
Yeah, please try clicking on PowerPoint.
yes, but it's not my not this presentation, and I had to change PowerPoint because it's for another session. Okay, there is okay.
Yes, and now, yeah, that's perfect. You can
Okay, so good morning, jury, organization committee, and the audience, and ladies and gentlemen. Today, I would like to present the effect of our research work titled Metformin Therapy in Patients with Acne Vulgaris. So at the beginning, it is worth of emphasize that the latest studies proves the correlation between acne and insulin resistance, and both of these problems share the same pathogenesis pathways. And increasing the serum level of insulin induces elevation of free IGF-1 levels, what is correlated increased androgen serum levels and inflammation. Also, altered glucose metabolism also caused increased levels of androgen as a consequence of insulin action on lowering the SHBG. So mentioned abnormalities encourage severe mTORC1 activity, which was detected in patients with acne. So why metformin? Metformin causes inhibition of mTORC1, and what is more, it reduced the serum level of IGF-1 and also may reduce the inflammation. And so the aim of our study was to estimate the effectiveness of oral metformin as a monotherapy in acne patients without PCOS or other endocrinopathies. Yes, so we started our study with database research, which was performed by 2 students independently. And we searched for databases, which are listed on the left side of slide. With using of phrases like metformin and acne, biguanides and acne, biguanides and acne, metformin therapy, and patients with acne. So as a result of the analysis or relevant factor, we decide to select the following inclusion criteria, and it was no PCOS and other endocrinopathies diagnosed, oral administration of metformin, metformin in monotherapy, GIGS assessments, articles allowing the determination of the decoherence effect size, and full text version available. So to perform our meta-analysis, we selected studies with the same methods of acne assessment, and all included studies contain data about acne evaluation in the global acne grading system. And it is a scale which assesses 6 areas of the body, which are the most common place where acne lesions can appear. And the second part of examination is assessment of the type of the lesions in point from 0 to 4. So all study selection process is presented in this slide. And as we can see at the beginning, the number of the articles was 172, but during the study selection process, only 3 of them meet our criteria. So as I said, we selected only 3 articles, which included only patients with only acne vulgaris, with idiopathic acne vulgaris, and treated only with oral metformin therapy without any other treatment. And in this place, it should be emphasized that the number of studies in which only metformin therapy was applied as a treatment method in acne was really small. So in this study, acne assessment was performed with use of GIGS. And as we can see, the GIGS assessment after applying metformin therapy was significantly lower in all selected studies. So the effect of our meta-analysis is subsequent. Evaluation of heterogeneity was performed using the E2 statistics, and the heterogeneity was approximately 64%. And our meta-analysis was performed using coherence D, which is defined as the difference between 2 means divided by standard deviation for the data. And the value of the Pearson correlation coefficient was assumed in our work 0.5 due to the lack of information in the original articles. And combined coherence D value was 1.47, one indicates statistically significant publication load, and also p-value was under 0.05 value, which indicates improvement of GIGS after metformin treatment in patients with acne vulgaris. So in conclusion, our meta-analysis indicates significant improvement in acne grading after metformin treatment, what might be an appropriate direction for acne treatment in patients with resistance acne to standard therapies. But what is the most important thing? It is still essential to conduct more adequate studies, which will be performed with precise duration of therapy with metformin and the same dosage of metformin administration in acne treatment, because it proves better material for clinical issue and for clinical improvements. Thank you very much for your attention. Thank you, our tutor and our doctors. They are references. Okay, so thank you.
Thank you very much for the presentation. If you could please, switch off the presentation and share your camera.
Yeah, of course.
Thank you. Now let's move on to the discussion. Are there any questions?
Did in the used free studies some information on potential negative aspects on glycemia, in serum glycemia in these patients using metformin?
There wasn't the glycemia wasn't assessed in the study, and this patient wasn't suffer from diabetes mellitus. It was healthy patients only with acne vulgaris, only with idiopathic acne, without any endocrinopathies.
That is obvious, but the question is if one can expect that use of this drug may make low the serum level of glucose. It was verified in these studies or not at all?
No, there is nothing information about that.
Are there any other questions?
Do you consider prediabetes as an endocrinopathy? Okay, so it wasn't an inclusion criteria, but
no, we excluded every endocrinopathies, but we didn't assess HOMA-IR in this study, and maybe we should to take a look about it and about the results in this study.
Yes, that's a very good conclusion. Thank you.
Thank you very much.
I ostatnie pytanie, jaki był, bo widzę dwóch autorów, jaki był podział pracy pani i koleżanki?
Both of us was researcher through the databases. We do it independently because we want to share a point of view. Also, we together try to figure it out with statistic things because it was hard for us both. So we tried to figure it out together. Also, I prepared some charts, and my friend prepared some article for the publications.
Dziękuję.
Okay, thank you very much.
Thank you.
This is the end of the discussion. And now I'd like to ask the next participant to present the work entitled "The Effectiveness of New Drugs Used in Anemia in Chronic Kidney Disease Dialysis Patients, a meta-analysis" by Dominik Lewandowski.
Yes. Can you hear me currently?
Yes, we can hear you. If you could please share your screen. Okay, and enter full screen mode.
Okay. Give me a second. Try once again.
If I think you need to share your whole screen on Zoom and then enter the...
Okay, the whole screen. Okay, is it visible now?
Yes, and please click F5 on your keyboard to enter presentation mode.
That's fine. One moment. Try. Do it once again. Okay.
And now just click F5 on your keyboard. It's in the middle at the top.
Yes, I'm clicking it, but I'm afraid it's not doesn't changing.
Then you can press the slideshow button at the top. It's covered now by Zoom meetings, but I think you can drag the window around.
The Zoom meeting. Okay. Is it working now?
Yes, it's working. If
Okay.
you can just drag the Zoom window to the side so it doesn't cover the presentation, and you can start when you're ready.
Okay. Okay, so I can start now, and good morning, everyone. My name is Dominik Lewandowski, and I want to show you the presentation of our meta-analysis about the effectiveness of new drugs used in anemia in chronic kidney disease dialysis patients, and it was prepared in the Department of General Surgery and Transplantology in Poznań University of Medical Sciences. Now I want to focus a little bit about pathogenesis of anemia in chronic kidney disease. So the main mechanism is the deterioration of kidneys' endocrine function that leads to the insufficient erythropoietin synthesis by interstitial cells of the kidney. And you can see on the left the pathological pictures of chronic kidney disease. It's very widely in the world because there are over 800 million individuals worldwide affected by this disease, and taking under advantage the fact of the society is growing older and older, it will be only a bigger burden for public health in majority of countries. Now, the aim of our study was to compare effectiveness of HIF-PHIS, it means hypoxia-inducible factor proryl hydroxylase inhibitors. In this group, there is roxadustat, vadadustat, and daprodustat, and intravenous erythropoietin stimulating agents as comparators in the treatment of anemia based on the assessment of hemoglobin concentration in the study groups. Here is the graphic showing what we did in our study. Our aim was to assess the efficacy, taking under advantage the standardized mean difference in the level of hemoglobin. And we decided to perform such study because of many studies about the HIF-PHIS, and also the factor is the potentially better compliance in this group of drugs than ESAS because they are taken orally. So it's more comfortable for patients, and that was our reason. There are our analyzed studies, and in the table you can see the baseline characteristics of studies included in the meta-analysis, and as you can see, the mean hemoglobin level had to be checked before study and after the study, both in the study group and comparator group, because it was our main tool to assess this efficacy. And to the left, you can see our inclusion and exclusion criteria of the studies. And as you can see, we assessed the study only where there were presence of ESA as comparator of our results. Mainly it was darbepoetin alpha and epoetin alpha. What is worth mentioning is that we did not include any study taking the placebo as comparator. Here you can see the bias assessment that was conducted using the Robbins-2 tool. And now I want to focus a little bit about on the meta-analysis itself. So it was performed using the HGG statistic of the fixed effects model. That is a measure of standardized mean difference. And we used also Eggers test to assess publication bias, and I2 statistic to evaluation of heterogeneity of the studies. So now I want to say about the roxadustat, because it's the only one drug that we could perform the meta-analysis on. As you can see on the figure 1 and figure 2, there is a meta-analysis of the efficacy and panel plot for visual depiction of publication bias. And here the standardized mean difference in the fixed model was 0.19 grams per deciliter. And also the heterogeneity between studies was 0%, so that's why we could perform meta-analysis on this drug. And also the results of Egger's test shows that there is not a statistically significant publication load. Okay, unfortunately with the next drugs, it is vadadustat and daprodustat, we were not able to perform meta-analysis. Here you can see on the figure 3 and figure 4 the meta-analysis of the efficacy and panel plot of publication bias. And here the heterogeneity of this between studies was 99.87%, and it was too high to perform reliable meta-analysis. And a very similar observation was in the daprodustat, in which the heterogeneity between studies was 99.86%, so very similar. And also here we could not perform the meta-analysis. So our conclusions are that roxadustat can be considered as an alternative to erythropoietin-stimulating agents treatment, as it is more effective in raising hemoglobin levels to dialysis-dependent chronic kidney disease patients. And as I told earlier, due to significant heterogeneity in the studies, it was not possible to analyze the efficacy of vadadustat and daprodustat compared to ESAS treatment. And limitations of our study are the conduction of research only for studies including dialysis-dependent patients, because there were lack of sufficient data for patients in stage 3, 4, and 5, but not dialysis-dependent in stage 5 of chronic kidney disease. And also I have to mention that we did not have ability to include every HIF-PHI drug into our analysis, because there were 3 randomized controlled trials examining the efficacy of molidustat, but one of them included placebo as comparator, what made us, of course, exclude this work, and it simply wasn't possible to conduct meta-analysis for only 2 randomized controlled trials. And thank you very much for your attention.
Thank you very much for the presentation. Now we will move on to the discussion. Are there any questions?
So I would like to ask you if you compared this in the effects of treatment in aspect of duration of therapy. I mean, not dialysis, but the drugs used in treating anemia.
You ask about the duration, like in many years' time, for example?
For example.
Okay, so it was difficult because this group of drugs is new, and it was not possible to find data telling us about the duration in many years' time. So we performed only for the studies only with this limited data. Yes, because we just couldn't find any information about it. There are many less publications, including the stack, so it wasn't possible fully.
Thank you.
Are there any other questions? If there are no other questions, thank you for your participation, and we move on to the next presentation, which is Post-Pandemic Health Challenges, Investigating Post-COVID Syndrome by Julia Hyrychel.
Ladies and gentlemen, thank you for the opportunity to speak today. I would like to draw attention to one of the most pressing challenges that still confront us, the long-term symptoms of the COVID-19, more widely known as post-COVID syndrome. The pandemic caused by the SARS-CoV coronavirus 2 has affected over 700 million people worldwide, resulting in nearly 7 million confirmed deaths. However, in the past few years, scientific attention has primarily focused on acute phase of the infection. However, an increasing body of data indicates that many patients experience persistent symptoms even after recovery. The introduction of the long-term COVID was necessary to describe this clinically and biologically complex group of patients who continue to transform medicine and the challenges faced by the healthcare system globally. The definition of long COVID includes symptoms that persist for more than 12 weeks post-active COVID-19 infection. Those symptoms may continue from acute illness phase, but also include new symptoms or exacerbation of previous ones. More than 50 long-term COVID-19 symptoms have been identified, covering both common symptoms such as fatigue and headache, as well as the rare complications such as neurological and thromboembolic complications. It's also worth mentioning that similar phenomena of prolonged symptoms were observed following previous coronavirus epidemics, such as MERS and SARS, suggesting that COVID could persist for months or even years. Pathophysiological mechanisms associated with post-COVID-19 syndrome include cellular damage through oxidative stress and effects of immune responses. SARS-CoV-2 infection leads to mitochondrial damage, reducing their ability to produce antioxidants, thereby leading to oxidative stress, and the excessive ROS generation in mitochondria may lead to damage in mitochondrial complexes, reduce ATP production, and increase cellular apoptosis. Immunological disturbances represent another significant aspect of post-COVID-19 syndrome. The virus triggers an immune response, which may lead to excessive cytokine production, causing a cytokine storm, damaging cells and tissues in organs, including the lungs and heart. PTS occurs in 45% of the post-COVID patients, with nearly 80% exhibiting at least one symptom. Additionally, patients who were not hospitalized experience these symptoms less frequently compared to those who were hospitalized, especially those requiring excessive medical care. Regarding demographic features and comorbidities, women, Caucasians, and individuals aged 40 to 60 years seems more susceptible to developing post-COVID-19 syndrome. Among affected individuals, common comorbid conditions include diabetes, hypertension, and obesity. The presence of common comorbidities correlates with the higher occurrence of long COVID, with significant relationships observed between the number of comorbid conditions and likelihood of developing post-COVID-19 syndrome. It is noteworthy that COVID-19 vaccination significantly reduced the risk of developing PCS. Source text analysis has shown that most common general symptoms occurring in more than 25% of cases were weakness, general malaise, fatigue, concentration disorders, shortness of breath, and reduced quality of life. Other analyses have pointed to headaches, hair loss, muscle pains, changes in smell and taste. Organ-specific syndrome occur less frequently than general symptoms, but they have significant impact on daily functioning of patients. Lung complications from COVID-19 are characterized by a range of symptoms, with cough and shortness of breath being the most common. More serious consequences, such as lung fibrosis, post-COVID-19, reduced DLCO, require particular attention. Other respiratory symptoms include shallow breathing post-activity, chest tightness, chest pain, sore throat, and excessive sputum production. Computed tomography of the chest often reveals ground glass opacity, along with various other abnormalities, such as consolidation, interlobular special thickening, and fibrotic changes. Persistent abnormalities are observed in significant number of patients, even 3 months post-hospital discharge, with fibrosis affecting a significant number of individuals experiencing the disease. The underlying mechanism of respiratory complications include direct viral effects, such as invasion of SARS-CoV-2 into alveolar cells. A significant role in pathogenesis is also played by the activation of physiological systems, such as kallikrein-kinin, renin-angiotensin, and coagulation system. Acute alveolar damage caused by macrophage infiltration, followed by the reparative process, can lead to fibrosis, driven by cytokines such as interleukin-6 and transforming factor beta. Symptoms of cardiovascular complication in the long course of COVID-19 include chest pain or pressure, palpitations, excessive induced dyspnea, dizziness, and increased resting heart rate. About 12% of the COVID-19 patients experience persistent heart damage, changes MRI, echocardiography, and elevated levels of B-type natriuretic peptide, suggesting that potential formation of scars and fibrosis of the heart muscle in later stages. Subclinical dysfunction of the left and right ventricles, and non-ischemic cardiomyopathy. The mechanism of cardiovascular complication in the COVID-19 include direct viral invasion, ACE2 inhibition, and inflammation of the heart muscle, pericardium, and conduction system. Neuropsychiatric complications after COVID-19 infection cover a wide range of symptoms, ranging from mild to severe. They include dizziness, brain fog, migraine-like headaches, disturbances in taste and smell, seizures, encephalopathy, and stroke. Psychiatric aspects also show disorders resulting from SARS-CoV-2 infection. Reports have noted that occurrence of chronic fatigue syndrome resulting from depression, PTSD, substance abuse, and other mental health issues. The mechanism of complications include direct viral neuroinflammation, systemic inflammation, microvascular thrombosis, neurodegradation, and potential disruption of blood-brain barrier.
The allocated time has expired. Please move on to the conclusions and end the presentation as quickly as possible.
In conclusion, I would like to emphasize that long COVID, known as post-COVID syndrome, remains a serious global challenge that affects millions of people, causing lasting and diverse health symptoms. This requires both intensive research and comprehensive support for those affected. Thank you for your commitment to those critical health issues.
Thank you for your attention. Now we will move on to the discussion. Are there any questions in the jury? Are there any questions in the audience?
Yes.
Hello, I have a question about thromboembolic events. You've mentioned that post-COVID syndrome can cause some of them, but I was wondering which one is the most common? Maybe stroke or a deep venous thrombosis, or maybe venous stroke. Have you recognized it or no?
Actually, but I think the most common damage caused by the thrombosis was for the renal system.
Okay, thank you.
Are there any other questions in the audience? If there are no further questions, we thank you very much for the presentation. Now we will move on to the next presentation, which is entitled Obesity's Impact on Maternal and Fetal Health, Preconception Strategies and Interventions by Mateusz Szczerba.
Hello, do you hear me?
Yes, we can hear you. If you could please put your presentation in full screen mode.
Okay, wait a minute. Okay. Okay. Dear Commission, dear listeners, my name is Mateusz Szczerba and I'm a fifth-year medical student and a member of Student Scientific Group affiliated to the Second Department of Obstetrics and Gynecology at Medical University of Warsaw. It is commonly known that obesity has a significant role in global health challenges nowadays. According to the WHO, a number of obese individuals has doubled since 1990. With no universally accepted definition of obesity specific to the pregnancy, the pregnant women are typically categorized as obese or non-obese according to their pre-pregnancy BMI, with a threshold of 30. The objective of this study is to analyze literature published within the past 5 years on the impact of obesity on pregnancy, childbirth, and maternal and child development, with a particular focus on the lifestyle modifications. The research that was made led to selecting 15 papers to conduct the review. With such knowledge, let's discuss the published data. According to the Anna Axelsson, the preconception obesity was associated with increased risk of complications during childbirth, including reduced percentage of spontaneous onset of labor, leading to doubled risk of stillbirth. And this underscores the importance of considering induction of labor in women with high-risk pregnancies who have gone beyond their due date. Additionally, obesity-related risk factors were connected with impact on increased occurrence of dysglycemia after delivery. Furthermore, the obesity was linked to mental health alterations of patients and higher occurrence of depression rates. The effectiveness of lifestyle changes depends on various factors. Identifying these factors would allow for a better alignment of the intensity and scope of interventions proposed in the guidelines. This underscores the importance of further studies to enhance the individual approach for each patient. It also appears crucial to determine the appropriate timing when the lifestyle changes would be the most effective. The literature suggests potential periods, such as the postnatal period and the time of medical visits by contraception users. Systematic contact with healthcare professionals and association with maternity topics could create an opportunity for effective lifestyle changes. Attempts to introduce additional supplementation in obese individuals during pregnancy were also analyzed. The results were inconclusive. This suggests that implementing appropriate changes in supplementation could improve pregnancy outcomes. Reviewed papers highlight associations with fertility rates, the presence of gestational diabetes mellitus, and other pregnancy and neonatal complications. The evidence suggests that obesity is associated with infertility, manifested as delayed conception and lower pregnancy rates. Consequently, there are widespread recommendations for weight loss to reduce the time to pregnancy and correct multiple mechanisms of poor conception. However, studies have shown diverse results in treating infertility with lifestyle modifications. Papers suggested that weight loss may have the strongest positive correlation with infertility treatment. Similar conclusions were proposed in studies on gestational diabetes mellitus. Patients who experienced weight loss achieved lower frequency of the disease recurrence. This had no impact on the fasting glucose levels during pregnancy. Safety considerations were also an important part of the conducted research. No significant increases in the pregnancy and neonatal complications were observed. However, there clear improvements were also not noted. An examination of the long-term outcomes of the interventions is crucial for determining the appropriate parameters to achieve the best results. A measure of effective lifestyle changes in obese individuals appears to be weight loss, which influences the outcomes after many years. Last but not least, we can present the following take-home messages. The preconception obesity is linked to higher childbirth complication risks, including stillbirth, as well as the increased post-delivery dysglycemia and depression rates. Postnatal medical visits or periods of contraception using could create an opportunity for effective lifestyle changes. Weight loss shows the strongest positive correlation with the infertility treatment and lower rates of the gestational diabetes mellitus. And the most important, that no elevated risk is associated with the safety of lifestyle modifications. Thank you for dedicating your time for this presentation.
Thank you for your presentation. It was very interesting. Now, let's move on to the discussion. Are there any questions?
So I would like to ask, because maybe I missed it, but you were talking about obese women, but among search strategy, you mentioned overweight or obesity. So what was the BMI that you focused on?
Yes, I mentioned the obesity in the background informations, but the whole research was made on the overweight and obesity individuals, because the data about the obesity was simply not enough in the last 5 years.
Okay, so the title of your study should be changed.
Okay.
Thank you.
Thank you.
Are there any other questions? Are there any questions in the audience? If there are no further questions, thank you very much for your participation.
Thank you.
Now I would like to ask for the next presentation, entitled 3D-assisted physician-modified stent graft implementation for abdominal aortic aneurysms treatment by Wiktoria Zasada.
Okay, can you hear me?
Yes, we can hear you.
Okay, that's great. So good morning, I'm Wiktoria Zasada, and I'm excited to present our research on 3D-assisted physician-modified stent graft implementation for abdominal aortic aneurysm treatment. This is our agenda for today. AAA, characterized by aortic dilation, affects 1.3 to 12.5 of people. Its etiology involves complex atherosclerotic and inflammatory processes, leading to an increased risk of rupture, particularly in larger aneurysms. To address AAA, we've seen remarkable advancements in endovascular techniques. Endovascular aneurysm repair, so EVAR, has shown superior outcomes compared to the open repair, especially in reducing perioperative mortality rates. Similarly, for distal thoracic aortic aneurysm, thoracic endovascular aortic repairs, or TEVAR, offers a safer alternative. Challenges such as endograft migration and endoleak have been observed, necessitating further interventions. This is where patient-specific models come into play. We must consider the economic implications. EVAR proves cost-effective in high-risk patients, but may escalate costs in low-risk patients. Immediate gains include reduced procedure time and decreased complications, facilitated by improved pre-operative planning and customized endovascular stents. Long-term gains involve enhanced recovery, cost savings, and the evolution of endovascular techniques through the continued integration of 3D printing technology. Okay. Following Cochrane Handbook guidelines adhering to PRISMA and registering study in the Prospero, we established clear inclusion criteria and conducted a thorough search across multiple databases and gray literature. Key outcome measures included procedure time, survival rates, success rates, and complications. Quality assessment utilized the minors tool to evaluate study quality. The data from 5 publications across several countries revealed a mean stent modification time of 65 minutes and a mean procedure time of 249 minutes, with optimal angiographic results achieved in 97% of cases on average. We measured treatment effects, including operation and modification times, as well as complication rates. Our analysis also included the 3D printing approaches utilized, highlighting the variety of software tools and printer models employed. Complications included endoleak, infection, neurological cases, renal complications, dissection, and post-op pain. Here, statistical analysis revealed considerable heterogeneity among the studies, indicating substantial variability in effect sizes. So we couldn't make the meta-analysis also. No significant publication bias was detected, ensuring the truthfulness of our findings. 3D printing demonstrates promise in urgent surgeries, expediting custom stent grafts delivery for high-risk patients with hyperacute symptoms. Previous reference studies on custom-made stent grafts emphasized the need for comparative analysis to evaluate the efficacy and safety of different approaches. Standardized training protocols are essential for consistency and reliability in surgical planning. Standardization of methodologies and workflows is crucial for optimizing procedural efficacy and enhancing patient outcomes. Moving forward, it's essential to address the variability in procedural duration and explore more direct diagnostic approaches to aortic lesions. Comparative analysis between traditional operating room procedures and 3D modeled endovascular operations offer valuable insights into complications and patient outcomes. Challenges include limited English language literature availability and insufficient detail in some articles. There is a potential risk of publication bias, and expanded data sets are necessary for a more comprehensive understanding of endovascular interventions utilizing the 3D printing technology. In summary, our review underscores the significant potential of integrating 3D models in the endovascular procedures. Despite persistent issues like endoleak and infection, 3D modeling shows promise in reducing complications compared to traditional methods. Technologies like deep convolutional neural networks enhance risk assessment and procedural efficacy, improving patient outcomes. Standardization efforts are crucial for ensuring consistent outcomes and reliable research. While complications rates remain globally consistent across the healthcare settings, the scarcity of published research highlights the need for further exploration and collaboration in the field. Okay, thank you so much for the attention. Here are some of our references.
Thank you very much for your presentation. It was very interesting. Could you please switch off your screen sharing and just leave on the webcam?
Mm-hmm. Sure. Okay.
Great. And now let's move on to the discussion. Are there any questions in the jury? Are there any questions in the audience? Well, I have a question from myself then. Do you know what kind of material was used in the 3D printing process?
Oh, I think it was in the table, one of the tables, but it's different kind of polymers, some resins, some medical approved by FDA and the European Commission materials.
And do you know if there is one kind of material that is used, or are there many different kinds?
They are different kinds. Correct.
Okay, thank you very much.
Thank you.
Now, let's move on to the next presentation, entitled Repetitive Transcranial Magnetic Stimulation, RTMS, in the Treatment of Postpartum Depression by Sopuruchi Angel Chidi will be joining us online.
Hello. Are you able to hear me?
Yes, we can hear you. If you could please share your screen.
Okay, is it okay?
Yes, it's perfect. You can start whenever you're ready.
Yeah. Okay, good day, ladies and gentlemen, and esteemed jury panel. My name is Sopuruchi Angel Chidi EKG, and today I'm going to be making a presentation on repetitive transcranial magnetic stimulation, RTMS, in the treatment of postpartum depression, PPD. This work was done by myself and my colleague, Mariam Abubakar from Kiev Medical University. Firstly, I'm going to be starting with the introduction, which states the history of RTMS. RTMS device was actually discovered in 1985 by Anthony Barker in Sheffield, England, and the principle behind this device was coined by Michael Faraday in 1830, where he discovered that changing the magnetic field can actually generate electrical currents. Further down in history, in 2003-2015, RTMS was also approved for the treatment of depression in Canada, United States, and in United Kingdom. In 2020, it was approved for the treatment of OCD in the United States. Based on our research and work done by myself and my colleague, we saw a number of explanations on what postpartum depression disorder was. And we chose this explanation because it encompassed everything that we believe to be postpartum depression disorder. It is one of the most prevalent mental health problems that would occur in women during childbearing years, and it has a very negative impact on both the mother and her child. It encompasses a strong feeling of sadness, anxiety, and tiredness that would last for a long period of time after the child is born. The feeling could make the mother not be able to take care of neither herself nor her child, and it has a period prevalence of 21.9% approximately, varying in different women of different symptoms. To understand postpartum depression is to understand the mechanism and the factors affecting this disorder. We start with dysfunction of the hypothalamic pituitary adrenal axis. We have neuroinflammation, imbalance of hormones, imbalance of neurotransmitters, imbalance of neurosteroids as well, altered synaptic connections, and epigenetics, which is the alternation of the genes based on human and environmental factors. On how the TMS device works as a whole. This device is made up of an electrical coil that is placed in the region of the head known as the dorsolateral prefrontal cortex, specifically the left dorsolateral prefrontal cortex, because it's believed to be the closest in connection to the limbic system that controls stress, emotions, and other behavioral factors and patterns. So this device placed in this area sends electrical currents through the magnetic fields generated by it, remembering the Michael Faraday's law. And these electrical currents go to the neurons and the synapses in this region to connect and correct the dysfunction of the hypothalamic pituitary axis, the neurotransmitters, and also altered neurotrophic factors for concentration, ultimately leading to relief of depressive symptoms and resulting in the reduction of corticotropin-releasing hormones and ultimately also reducing the salivary control concentrations. For our studies, we use the Prisma analysis to actually conduct both a systematic review and a meta-analysis. We use various databases like PubMed, Biomed Journal, Embase, and Scopus as well for this study. We had a total of 122 records and 115 patients. These records were then revised, and we excluded records that had duplicates, records that were done with experiments on animals, use of RTMS in treatment of postpartum depression, but with the use of antidepressants as well, and then insufficient data, leaving us with 4 main studies for our review and also for our meta-analysis. And now for the results, which is the meta-analysis. We use the comprehensive meta-analysis software to actually conduct the meta-analysis using the 4 studies. We conducted a randomized control trial for the treatment of postpartum depression with RTMS, and our results indeed showed that RTMS does elevate the effects of postpartum depression. We also compared the values at baseline, that's before the treatment, and also at week 4, using the mean and the standard deviation for this work. We came out with a mean effect size of 0.64 with the 95% confidence interval of 0.36 to 0.92. Our study showed a common effect size of 0.64, which is medium according to coherence criteria in the meta-analysis displayed. For our studies, we did come across a number of limitations. We had the issue with sample size. So the sample sizes were seen to not be large. Also, the marital status of the women were not established, as absence of a partner can actually lead to postpartum depression. So it is indeed a risk factor. And then we also had the paucity of the research for these studies as well. In conclusion, for the work done by myself and my colleague, we see that the concerns that women do have for the presence of drug metabolites in their breast milk for their babies will make them to avoid antidepressants. And repetitive transcranial magnetic stimulation is a non-invasive alternative approach that actually offers a lot of promise. Based on our research and meta-analysis, strong evidence shows the support of the effectiveness of RTMS in the treatment of postpartum depression. RTMS has shown promise in reducing the depressive symptoms, achieving remission in patients, as well as producing favorable long-term outcomes with very minimal side effects like little discomfort during the treatment in the region where this coil is placed, or mild headaches. But patients usually, it's an outpatient procedure, so patients usually go home after treatment. Though further study needs to be conducted to establish standard protocols and guidelines for the treatment of postpartum depression with the RTMS therapy. Overall, RTMS indeed offers a valuable non-invasive treatment option for women that do suffer from postpartum depression based on our studies. Thank you so much for your attention, and I'm open to more questions. These are the list of references used for our work, and yeah.
Thank you very much for your presentation. Now we will move on to the discussion. Are there any questions in the jury? Are there any questions in the audience? Well, I'll ask a question then. Is RTMS used in other neurological conditions?
Besides postpartum depression, it could actually also be used in normal depression. And according to the research done, it could also be used in stroke treatment as well, and little time seizures as well. But it's still a work in progress for other treatments, but specifically for the meantime, it's used for depression and postpartum depression.
And do you have any data of the effectiveness of RTMS compared to a pharmacological approach?
Based on the research done, there are 2 things I'm going to say. Firstly, women do like to avoid the use of this antidepressant. So this is like an alternative option. And this option actually shows strong promise in long-term outcomes. So women do achieve remission with this treatment for a very long time. So it actually shows a high efficacy. But the major problem is not established standard protocols. So there are not standard protocols yet established for the treatment. So yeah.
Very interesting. Thank you very much.
You're welcome.
Now I would like to ask the next presentation, entitled The Paradox of Weight and Power, the Most Suitable Animals for Atrial Fibrillation Models, by Anna Lupsor. We can see you. We cannot hear you yet.
Yes, good morning.
Yes,
Do you
hello.
hear? Can you hear me
Yes,
now?
we can hear you.
Okay. And do you see my presentation? Oh no.
Yeah, we see your screen. Just
Yeah,
not.
my screen. Okay. No, I think it should be all right.
Okay, that's all right. You can start whenever you're ready.
Okay, thank you. Good morning. My name is Ana Lupșor, and I'm a fifth-year medical student at the University of Medicine and Pharmacy in Cluj-Napoca, Romania. I want to present you a review of the most suitable animals for atrial fibrillation models that I conducted together with my colleague Alexandru Necula and under the supervision of our tutor, lecturer Gabriel Cizmaru. This is the table of contents. I will start with introduction, materials and methods, the different atrial fibrillation models, results, and the conclusion. Atrial fibrillation is one of the most frequent arrhythmia that appears in humans, with up to 33% in the last 20 years. Its mechanism is not fully understood. It can rely in macroentrant circuits due to fibrosis or overstimulation. But in order to find better treatments than cardioversion and the present antiarrhythmic medication that are used, there is a need for atrial fibrillation animal models for conducting experiments. The materials and methods that we used was a data research on PubMed, UpToDate, and Elsevier. We researched different experiments in atrial fibrillation induction with animals, and then we focused on the specificity of each one of each kind of animal and how the link between the weight and atrial fibrillation sustainability to analyze which particularity is best for each model. The first mechanism that we analyzed was the one medication induced, and I will present you two of the medications. One of it is the acetylcholine that can lower the heartbeat rate and it can induce atrial fibrillation through the lowering of the action potential, while streptozocin, which is a chemotherapeutic treatment, together with other types of medications used in oncology, cause fibrosis. And on the long term, also induce atrial fibrillation, because fibrosis is one of the most common mechanisms that is known. On the other hand, beta-adrenergic stimulation like isoproterenol, adrenaline, or norepinephrine, which increase the heartbeat rate, also cause atrial electrical remodeling and fibrosis through inflammation. And in an experiment conducted in mice and dogs, it showed that high rate pacing lasted less than 30 seconds before the administration of norepinephrine, but then it led up to 10 minutes of atrial fibrillation sustainability. This was due to the ionic changes in the calcium and the potassium channels. One of the most feared postoperative complications of cardiac surgery is inflammatory pericarditis. And this was replicated in goats and dogs through the application of the talcum powder after pericardiotomy. It showed that it induced atrial fibrillation in long term because of inflammation, and this inflammation was also shown on a histopathological analysis as a bifurate epicardial surface surrounding the talcum powder. The inflammation on the long term also caused the atrial fibrosis. Another important cardiac disease that can cause this type of arrhythmia is mitral valve regurgitation, which was replicated in mice and pigs through leaflet puncture under a transesophageal echocardiographical guidance. And it caused atrial fibrillation only after 10 seconds rapid pacing. And this the fibrillation was sustained for some minutes. Other medications, even antiarrhythmic medications that are used for preventing ventricular tachycardia and extrasystoles, like amiodarone or adenosine can cause through direct mechanisms or indirect mechanisms, like thyrotoxicosis. They can cause atrial fibrillation, and this is due to the blocking of the potassium channels and other ionic mechanisms. The most prevalent mechanisms that are used actually when after a thorough analysis of different experiments was burst spacing, which consists in the introduction of a catheter directly intracardiacally or indirectly through the esophagus in different kind of animals, and then the electric stimulation. The most used animals are the big ones like horses and dogs, which can be awake during the procedures and don't even need sedation or anesthesia. A continuous atrial high-frequency electrical stimulation of 40-50 Hertz was sufficient enough to induce hours of sustained atrial fibrillation, up to 24 hours in goats, and even weeks in horses. Rodents were considered until some years ago, they were considered resistant to AFib induction, only electrical stimulated because of their small atrium and the small quantity of myocardial surface. But an experiment conducted last year discovered that adrenergic activation by intraperitoneal norepinephrine increased the atrial fibrillation duration, and so mice can be used also for analyzing different kinds of medication and their effect on causing atrial fibrillation. Here this is the table that shows the results of time sustainability in animal models that can range from seconds to minutes in mice or rats to up to hours and weeks in horses. It can be shown that the weight of the animal and the dimensions are correlated with the time that atrial fibrillation can be sustained. The results is mostly a comparison between small and large animals, depending on versatility and ethics. Small animals are more versatile and they're useful in demonstration of the underlying signaling pathways that may contribute to human atrial fibrillation. Being more versatile, then they can be used to test the different kinds of medication, their adverse effects, and their effects on the heart, on the atrium. But the problem of the rodents is that they are small. The atrial fibrillation is not so long sustainable, only after the injection of norepinephrine, as I showed before. And they are not capable of spontaneous atrial fibrillation in the absence of severe perturbation. So the researchers need to use genetic mutations in rodents. On the other hand, large animals do not need anesthesia or sedation. They can be awake during the procedure, and the atrial fibrillation is sustained longer because for analyzing different kinds of medication, there is a need of up to 50 weeks of sustained atrial fibrillation to analyze all their effects so that they can be applied in humans in the future. On the other hand, the ethics has to be also analyzed as there is a lower social acceptance rate of using larger animals, which are not considered as laboratory animals for medical studies. So the procedures of inducing it in mice would be more efficient. As a conclusion, experimental atrial fibrillation can be performed on different animal models by various mechanisms, each being more or less suitable for a different objective. It is important that researchers had a well-defined purpose of the study for a statistically significant experiment, and they found an equilibrium between versatility and sustainability in atrial fibrillation models. Thank you. This is the bibliography that we used, a part of it.
Thank you for your presentation. If you could please turn off your screen sharing, just leave the video.
Yes.
And now let's move on to the discussion. Are there any questions in the jury? Are there any questions in the audience?
So much. Hello, thank you for the wonderful presentation. I have one question. Even though you haven't conducted any clinical studies relating to that, obviously, who exactly decided that larger animals do not require any kind of sedation for the testing of atrial fibrillation? I would like to know.
I don't know who required it, but I found experiments in which there was no sedation used for that. I don't know who required it.
Yeah, I understand. That's mostly on the ethics part. That's why I wanted to know. Thank you so much.
Yes, I know it's not so ethical, but it was surprising for me, and it's maybe more cost efficient if the people who did that for them.
I understand. Thank you.
Thank you too.
Are there any other questions in the audience? If there are no other questions, thank you very much. Thank you very much.
Thank you. Bye.
And I will now ask to present the next work entitled The Impact of Smoking on Postpartum Depression, a Systematic Review by Karol Knysak.
Ladies and gentlemen, dear scientific jury, my name is Karol Knysak, and today I would like to present to you the results of our systematic review entitled The Impact of Smoking on Postpartum Depression. But firstly, I would like you to ask a question. What emotions do we usually associate with a childbirth? Is it a joy, a peace, love? Why are those the positive one? And is it true for every mother? Unfortunately not. A postpartum depression is a type of mood disorder that affects some women after childbirth. It's associated with feeling of sadness, anxiety, and also fatigue, which can interfere with the ability of mother to take care of herself or her baby. World Health Organization requires that the onset of the episode, need to be within the 6 weeks of delivery. However, the scientific consensus is not yet established here. Some scientific data says that it can occur even after 12 months after delivery. And according to the newest scientific papers, the prevalence of such condition is approximately 10 to 15% of pregnant women. We wanted to know why some women prone to this condition and the other not. While reviewing the risk factors, we identified the primary risk factors, which is depression either during pregnancy or before pregnancy. However, there are many and various secondary risk factors that we assessed. While studying the importance of this matter, we asked ourselves whether smoking cigarettes is one of them. And that's how we created the aim of our study. In order to do it scientifically appropriate, we followed the PRISMA guideline and searched 2 big databases, which is PubMed and Web of Science. Our inclusion criteria where we wanted to search for articles which were original research paper written in English. We conducted our search on November 2023. We looked for papers from last 5 years, and we wanted the depression to have a postpartum onset. This is how our advanced search strategy looked like in PubMed and in the Web of Science. And this is our PRISMA flow chart. We identified over 300 articles, from which we assessed 32 for eligibility. And then, out of them, we managed to decide 10 original research papers dating from 2019 to 2023. As you can see, the research papers were from around the world, which confirms my earlier word that this condition is among various cultural and around the world, women around the world. As for sample size, we managed to get over 600,000 pregnant women. And I have prepared some bullet points from every paper included in our research. Every research confirmed that smoking during pregnancy increases significantly the risk of postpartum depression. Another interesting factor is that researchers from Japan said that if you've been smoking before pregnancy, you also have an increased risk. However, if former smokers who had quit smoking more than 5 years did not show an increased chance of postpartum depression, thus indicating that time of cessation plays a huge role. The researchers from Sweden said that smoking before pregnancy may play a role in the development and persistence of depression symptoms. And last but not least, researchers from South Korea said that the more cigarettes you smoked, the highest was your risk for postpartum depression. In conclusion, we as a healthcare providers need to discourage women, whether before pregnancy or during pregnancy, because it is a well-known and established here risk factor for postpartum depression. And if we not yield results, we should at least aim to reduce the number of cigarettes smoked. Thank you very much for your attention. And now I would gladly answer your question.
Now, if the jury has any questions, please.
Thank you for your great presentation. It seems like everything was done really good. I have only 2 questions. The first question is related why you selected only 5 years for the period of research for the papers. And it used to be that, I know it's just a systematic review, but it would be interesting to check whether, as a result of meta-analysis, what is the mean risk ratio for the depression in women who smoked cigarettes.
Thank you for your question. Of course, we've decided with my research team that we will try to find the newest data, and thus we decided to look only for the 5 years articles from the last 5 years. Furthermore, answering your second question, a meta-analysis would be necessary to highlight and to answer this question. We only here managed to do a simple systematic review, however, indicating that needed meta-analysis is important to highlight and to show us how many cigarettes, or whether the cigarettes only, or is it associated with so-called characteristic of the person who is smoking, as for example in the Parkinson's disease, whether smoking is preventing factor, but we do not know whether smoking or the type of personality. And thus here it's interesting topic for another and further research.
Are there any other questions?
W Polsce takich badań jeszcze nie mamy.
Unfortunately not, but it's an interesting topic for an original research paper. So we will see in the future how this matter looks like in the Polish field.
A czy w którymś z tych badań bierne palenie również było brane pod uwagę, czy taki czynnik
while looking for interesting research papers, we excluded those papers. There are papers that said that this type of smoking as well increases the risk. However, we decided to not include them in order because we wanted here the topic of the main, our work was whether smoking cigarettes like an active part. However, there are interesting articles about this issue and they confirm that this participating in smoking around is also an increasing risk factor.
Thank you. Are there any other questions or questions in the audience? If that's all, thank you very much. The presentation was especially well done. I will now ask the next presentation entitled Methylene Blue Utility in Patients During Septic Shock, Systematic Review with Meta-Analysis by Jakub Rąpała.
Ladies and gentlemen, honorable jury aboard, I have immense pleasure to present you the results of our review concerning the utility of methylene blue in patients with septic shock. And main purpose of our study was to investigate impact of this drug on mortality, mean arterial pressure, and lactate levels in those patients. These parameters are indications of appropriately vascular resistance and perfusion of tissues, and their pharmacological control is one of main target of critical care in septic shock. Methylene blue is a thiazide dye, which is mainly used in methemoglobinemia. In methemoglobinemia, after cyanides or carbon oxide poisoning. And in context of shock, its activity is based on inhibition of guanylate cyclase and endothelial nitric oxide synthase, which leads to reduction of cyclic GMP synthesis. And cyclic GMP is molecule which causes vasodilatation, providing decrease of vascular resistance, blood pressure, and tissue ischemia. And methylene blue, by blocking synthesis of cyclic GMP, counteracts those effects. As you can see in this table, methylene blue is one of the drugs mentioned as alternative pharmacotherapy for vasoplegia syndrome, which is defined as persistent severe hypotension due to low vascular resistance despite high cardiac index and aggressive fluids and vasopressors therapy. And criteria which describe vasoplegia are found in many other diseases, and one of them is septic shock, which was an object of our study. In septic shock, first-line agent in hemodynamic management is norepinephrine. And due to guidelines from 2021, there are also high-quality recommendations for applying dopamine and moderate recommendations for vasopressin. And in refractory shock, it's recommended to add vasopressin or further not effective epinephrine instead of increasing dose of noradrenaline. And methylene blue isn't concluded in these guidelines, but as well as other drugs like teriparatide or hydroxycobalamin, its utility in this disease still investigated. In our review, we searched 3 databases, PubMed, Scopus, and Embase, and our queries were shock or septic shock and methylene blue, and we got nearly 400 articles. Our inclusion criteria were following. We included studies with at least 5 patients, which have to be adults and were administered methylene blue. And we excluded case reports, experts' opinions, other reviews, and studies with pediatric patients and with missing outcome data. After identifying duplicates, screening and assessment of eligibility from studies, we included 17 which were published between 1995 and 2023. Due to the tools to risk of bias assessment, we used ROB2 protocol for randomized and Robbins for non-randomized studies. Our main outcome was mortality, and general odds ratio was 0.56 and p-value was 0.14 in mortality in randomized controlled trials. And as we can see, in population with methylene blue, mortality was lower than in placebo, but the difference isn't statistically significant. Second outcome of this review is that more than half of patients doesn't respond by increasing arterial pressure to methylene blue administration, which is followed by difference in mortality on advantage of patients who respond. And in most of studies, responders were defined as patients with arterial pressure elevated at least 10% after methylene blue administration. And mean arterial pressure elevation in responders were at least 7.7 millimeters. Meanwhile, in non-responders, there were practically no increase in every study which contained this data. In our results, we wanted to underline lactates levels and arterial pressure changes, and most of studies show reduction of lactates, but the only randomized controlled trial which contains this data displays no difference before and after administration, and in every study, arterial pressure after methylene blue increased, which is statistically the most significant outcome of our study. In summary, we can slide out four main conclusions. Methylene blue increased arterial pressure in nearly half of patients with persistent septic shock and has visible but statistically insignificant impact on mortality in those patients, and further investigations, especially randomized controlled trials with greater populations, are required to explore impact of methylene blue on mortality. Thank you for your attention.
Thank you for the presentation. Now we will move on to the discussion. Are there any questions in the jury?
Thank you for your presentation. I'm just wondering if you used enough terms for PubMed searching, etc., because you used only two, right, definitions. I know that they are kind of similar, but I'm afraid that in the literature there could be more definitions of sepsis.
Yes, we have same things. What's about?
Yeah, so probably that could rise a number of papers that you could review.
Are there any other questions in the jury? Are there any questions in the audience? If that's all, thank you very much. And we will now move on to the next presentation entitled Leaky Gut, Dysfunctional Lungs, Applying Zonulin to Respiratory Diseases by Julia Ślążek.
Good morning, my name is Julia Ślążek, and today I would like to present the work Leaky Gut Dysfunctional Lungs, Applying Zonulin to Respiratory Diseases. Zonulin is a protein known as prehaptoglobulin, and it is a protein modulator of intracellular tight junctions. Usually, it is used as a marker for intestinal permeability, and its role overall is to regulate the permeability of tight junctions. It is mostly used as the assessment of intestinal permeability in autoimmune diseases such as diabetes. But in this case, the aim was to review the significance of zonulin in terms of respiratory diseases, because this has been started to explore around 10 years ago, and I am a big fascinator of pulmonology, so I decided to go into this way. So here is a summary of the materials used by PICOs. The population that we've determined was adults in respiratory infections and the most common respiratory diseases, because the work is still limited, the research is still pretty new. The intervention was the biomarker analysis, and we compared the treatment procedure and the diagnostic algorithm. The outcomes that we found was the efficacy of the use of the serum zonulin levels in terms of prognosis in the patients that were sick. In the study design, we only used random control studies, case control, and we have decided to use the work published after 2013, because at the start we wanted to do only the last 5 years, but there's limited research yet, so we extended our methods. Here is the search strategy example by PubMed. We used also Scopus and Embase databases. This is only an example because we have every single disease. We always search zonulin and the name of the disease, as well as zonulin respiratory, zonulin lungs. And after we have done our search strategy, this is a similar data. We have found in total 107 articles. Out of those, 47 were duplicates, and the record screened was 60. Once we screened the articles, some of them used animals in research, so we decided to exclude those. And we have left then 44. After assessing the 44, we also excluded 10 because they were either not found in English or they were published only as an abstract. So we decided to exclude them from our review, leaving 34 for analysis. This is the summary of results out of all of the articles that we've compared. So we decided to stick with asthma, community-acquired pneumonia, coronary COPD, COVID, and obstructive sleep apnea. And overall, serum zonulin levels were significantly higher in patients with any of those diseases. In terms of COVID, I found that most fascinating because this was also correlated with interleukin-6. So essentially, the higher level of zonulin corresponded to the marker of systematic inflammation, because obviously, since it regulates intestinal permeability, the higher the level, the more permeability to different pathogens as well, and those markers of inflammation. And so, in terms of COVID, for example, the main use was for the treatment, because it was used as a prognostic marker. The higher the level of zonulin, the higher the possibility that the patient will die. So in this case, they have most of the research has used the zonulin receptor antagonist, and this helped to decrease the severity of the disease, which I, for one, find very fascinating, because how does the gut correspond to the lungs? And for most of those, in terms of sleep apnea, this was interesting for me as well, because they have actually found that there is a role between the level of zonulin and the association between sleep apnea and liver injury. So the higher the level of zonulin, the more probable it was that the patient will have liver injury. So this was a little bit of a surprise for me. The limitations of our results was that most of those studies used a relatively small number of study participants. It was usually approximately 30 to 100 people, so it is not a very big database. There were also various study group ages, because they either use senior citizens or young adults. So there was also a possibility that those groups would vary. And not all of the studies adjusted for confounding factors, such as diabetes and other diseases that could potentially raise zonulin level. And the magnitude of associations, therefore, should be interpreted with caution. And this is our conclusion. So future research is definitely needed, because still, this is a pretty new area. And the relationship between disease severity and this concentration of zonulin should be studied more, because maybe potentially it could have some possible nice consequences in terms of treatment determination and the prognosis of treatment. But on the other hand, zonulin is not a very cheap method of diagnostics, so I don't know if it is actually that good in terms of those. But to be honest, after doing this review, I think that it might, in terms of severe diseases, it might be useful to research. And I wouldn't be myself, and I wouldn't be a good member of my scientific circle if I didn't put a quote on the end. So all disease begins in the gut, and therefore the correlation between lungs and gut. Thank you for your attention.
Thank you very much for your presentation. We will now move on to the discussion. Are there any questions in the jury? Go ahead.
Thank you for your great presentation. It was really good. But I'm just wondering about the PICO and method that you used. I mean, it used to be that PICO should be very precise. You used respiratory disease instead of being more precise for the specific disease,
yeah.
which is kind of not very common. So could you please explain why you select all the respiratory disease instead of focusing only one disease?
Yes, so we focused on all of the respiratory diseases that we found had a publication based on zonulin, because most of those publications in each of the diseases, it was around 4 to 5. So it wasn't a lot to focus on only one of the uses. And most of them also measured the exact same thing, so they had the exact same conclusions. So that is why we extended to do more of the respiratory diseases. At the start, our presentation had the topic, our whole research had the topic zonulin overall applications. So we still kind of had to make it a little smaller because the professor wanted us to research every single thing. So I managed, as I said, I am a big fan of pulmonology, so I managed to persuade him to let me use respiratory diseases instead of everything. So it was still supposed to be bigger.
Okay, thank you. And the other question is, it could be also obvious, but you just limited your research for the respiratory journals. Is that right? From what methodology, what I've seen in the
yes.
presentation. And of course, it's not illegal, but I would rather suggest to allow more journals to be searched on.
Okay. Thank you.
Are there any other questions in the jury? Are there any questions in the audience? If that is all, thank you very much. The next presentation, entitled "Does Vaping Mean Exacerbating in Skin Diseases? E-cigarettes in Dermatology," will not be presented today. So we will move on to the next presentation, entitled "Conha bullosa in Romanian Patients, Prevalence, Morphological Classification, and Clinical Significance," by Maria Bianca Andrei.
Hello, everyone. Can you see my screen?
Yes, we can see your screen, but please, if you could enter a presentation mode. Great, just a second. Okay, if you are ready, you can start.
All right. Hello, everyone, dear jury and dear people from the audience. My name is Maria Bianca Andrei. I am a medical student in the 3rd year at the University of Medicine and Pharmacy, Grigore Tepopa from Iași. And today I am going to present you the Conha bullosa in the Romanian patients, the prevalence, morphological classification, and clinical significance. Here is my table of contents. To begin with, the pneumatized cavities within the skull exhibit numerous anatomical variants, with the aberrant pneumatization of the middle turbinate being notable in both prevalence and clinical impact. While anterior or posterior rhinoscopy can clinically identify this anomaly, spiral computed tomography or CT and cone beam computed tomography scans serve as the gold standard for the diagnosis. The aim of our study is to determine the prevalence of conca bullosa in the Romanian population and the distribution of it according to sex and age groups. Moreover, we propose a new clinical classification based on the conca bullosa morphology, and this review highlights the association between conca bullosa and rhinosinusitis. We conducted a retrospective randomized study involving 106 non-traumatic patients with the ages in between 60 to 20 who underwent craniocerebral CT scans in between 1st of July 2023 and 31st of December 2023 in the Iași Clinical Rehabilitation Hospital. Artifact-free CT datasets containing the entire viscerocranium and skull base were included, while the exclusion criteria are the CT scans of patients with a history of skull trauma. From these 106 patients, 57, representing around 53.77%, presented conca bullosa, and from these, 30 had the bilateral form, while 27 presented the unilateral form. Statistical tests showed a uniform distribution across the age, as we can see in the first table, and the gender groups, as we can see the prevalence in the second table. Our proposed classification revealed 9 subtypes with the mass effect in both in the axial plane and in the coronal plane, as we can see in the table 3. Here are the morphologic types. Our classification showed statistical significance, which was observed between the subtypes 1, ABC, and subtypes 2, ABC, indicating a predominance of the lamellar type over the bulbous type. Next, in the table 4, I also attached the classification for the conca bullosa and the morphology-wise demographic distribution. In the next figures, I am presenting you the CT scans of the axial and coronal view. In the first image, we have the type 1A, where we can see the lamellar conca bullosa that is located in the anterior half of the left middle turbinate. And in all the images, the conca bullosa is indicated with the arrow, as we can see here. In the figure 2, we have the first type B, and the conca bullosa is located in the posterior half of the right middle turbinate. In the next CT, we have the type 2A, whereas the bulbous conca bullosa is located in the anterior half of the right middle turbinate. And in the last image, in the figure 4, we have the type 3A, where the extensive conca bullosa is located in the anterior half of the right middle turbinate. The therapeutic management of the aberrant pneumatization in the middle turbinate is complex. It addresses both the malformation and coexisting rhinosinusoidal disorders. Some authors indicate the use of saline flush, steroidal and non-steroidal anti-inflammatory drugs, and antibiotics as the initial treatment. After this initial treatment, the patient should be reinvestigated to identify the anatomical variants masked by the inflammatory process. The second therapeutic line is the surgical treatment, and it has two directions. First one would be the surgery of the morphological anomaly, which is an etiological treatment. And if, for example, the first line treatment has failed, can be also indicated the surgery of the sinus cavities. In conclusion, concabulosa exhibits a high prevalence in the studied cohort and shows no significant variations related to age or gender, supporting its malformative origin. Our proposed classification offers improved understanding of the local mass effect by the concabulosa. And here are my references, and thank you for your attention.
Thank you very much for the presentation. We will now move on to discussion. Are there any questions in the jury?
I would like ask about the very wide age range from 70 to 94. Is
Yeah.
a strong value of the study or rather limitation? What do you think?
I didn't understand the last part. Is it a strong what? Can you?
Because the range, age range from 7 to 94 is is not very wide. So is this a strange side of the study of should be considered rather as a limitation of the study?
Thank you so much for your question. I think this can be a limitation of the study because, of course, if the age range was more precise, then the results also could be more precise. But this was the materials, let's say, that we could work with.
Are there any other questions in the jury? Are there any questions in the audience? If there are no other questions, thank you very much.
Thank you.
We will now move on to the next presentation entitled The Impact of Sarcopenia on Post-Operative Complications After Pancreatico-duodenectomy by Jakub Ciesielka.
Thank you so much. I know that this is a very difficult term. Can I have a pointer? Thank you so much. Dear committee, dear colleagues, it's my great honor and pleasure to be here. I would like firstly to express my gratitude to Professor Beata Jabłońska, who is responsible for conceptualization of that project entitled The Impact of Sarcopenia on Post-Operative Complications in Patients Undergoing Pancreatico-duodenectomy. As we know, up to 2030, pancreatic cancer will be the second cause of cancer-related deaths. And if you can see on that chart, this still increases rate of survival in patients with other, for example, gastrointestinal tract cancer, cause the pancreatic cancer will be the second cause. However, despite the advances in systemic treatment, the treatment for patients with pancreatic ductal adenocarcinoma remains highly insufficient. The sarcopenia, known as disseminated muscle loss, is a reflection of cancer-induced cachexia, and it is estimated that this state occurs in 70% of patients with PDAC. However, the association between the sarcopenia and post-operative complication in that patients remains vague. Here we present a potential model treating the relationship between the tumor, the interleukins used by derived by the tumor tissue factors, and pituitary gland and fat tissue, as well as muscle tissue, All these factors lead to increased protein catabolism and resulting in sarcopenia. So we attempt to evaluate the potential impact of sarcopenia on patients undergoing pancreaticoduodenectomy. Using the following keywords, pancreaticoduodenectomy or pancreaticoduodenectomy and sarcopenia on low skeletal muscle, we primarily identified 254 studies after regarding inclusion and exclusion criteria. We finally included 26 studied in the analysis. We evaluated those studies in terms of number of patients included in the study, the histological type of the periampullary tumor, type of pancreaticoduodenectomy, the parameter defining sarcopenia, as well as sex-adjusted cutoff values defining sarcopenia, as well as surgical complications. Here in our extended table of the results, you can see that all of the authors use different parameter defining sarcopenia, just like total psoas area index, total abdominal muscle area, or skeletal muscle index with different cutoffs. It was challenging for us. However, those parameters are standardized and sensitive parameters defining the sarcopenia. Here, we also evaluated post-operative complications in terms of post-operative pancreatic fistulas, delayed gastric emptying, as well as intra-abdominal abscesses, myosurgical complication, intra-abdominal hemorrhage, as well as increased mortality. We extracted odds ratio from each study, as well as the percentage comparison with an adequate p-value. Our study revealed that sarcopenia was significantly associated with increased rate of post-operative pancreatic fistulas. Regarding all types, the odds ratio range from 2/65 to 4/3, as well as delayed gastric emptying. Authors did not use odds ratio for evaluate infectious complication, myosurgical complication, or intra-abdominal abscesses. However, those studies also underline increased and it was a significant increased rate of post-operative complications. Also, the sarcopenia was a great predictor of increased mortality with odds ratio above 6-fold. To conclude, sarcopenia was associated with a higher incidence of post-operative complications, including post-operative pancreatic fistula, delayed gastric emptying, hemorrhage, as well as infectious complication, intra-abdominal abscesses, and post-operative hemorrhages. As well as this state was correlated with increased mortality. In the future, we are planning to perform a future grant project in which we are going to evaluate the impact of sarcopenia in our high volume center on post-operative complication in order to predict a potential model that can stratify the patient before the operation in order to reduce the post-operative complication and to extend the overall survival. We know that this is a small step in optimizing the surgery. However, I'd like to end with the quote by Martin Luther King: "You don't have to see the whole staircase, just take the first step." Thank you for your attention. Feel free to ask some questions.
Thank you very much. Are there any questions in the jury? Are there any questions in the audience? Well, I'll ask a question then. What is your personal contribution in the work?
So I was responsible for data extraction as well as the preparing this graphic, this potential model regarding sarcopenia as well as data processing. And we prepared an article next month. We are going to send it into the journal.
That's very nice. Thank you very much. Now we will move on to the next presentation entitled The Role of Sex Hormones in Physiological Adaptation and Athletic Performance in Women with Hyperandrogenism by Kamil Górecki.
Can I get the pointer? Good morning, ladies and gentlemen. My name is Przemysław Prokop, and Kamil Górecki and Aleksandra Kreczynska are my colleagues. And I am a member of our team research from the first department of anatomy, Faculty of Medical Sciences in Katowice, studying the impact of sex hormones in physiological adaptation and athletic performance in women with hyperandrogenism. On behalf of myself and my colleagues, I'm honored to present the results of our study. Before I start, special thanks are owed primarily to our tutor, Dr. Tomasz Lepich, for his supervision and assistance of the project. Hyperandrogenism in women's sports is a topic that has been controversial for years and has been discussed and debated internationally. It concerns the participation of women with elevated testosterone levels in sports competition, especially in disciplines where physical strength and performance are crucial. Gender categorization in sports has a biological basis and stem for significant physiological differences between men and women. Its purpose is to ensure fair competition and equal opportunities for all participants. The issue of hyperandrogenism in sports is often arises in the context of controlling the fairness of competition, and many researchers and sport activists argue that high levels of testosterone can give an unfair advantage. It's worth mentioning that the hyperandrogenism is not always due to doping or unfair practices. Often it's a physiological condition that can result from individual genetic characteristics. The aim of the study was to define the effects of sex hormones on female body metabolism, particularly elevated androgen levels, and to demonstrate the impact of athletic performance in elite athletes. A systemic review. Yeah, it works. Sorry. The systemic review explored the link between androgen levels and athletic performance improvement. Google's Scholar was searched using keywords like hyperandrogenism, female athletes, sexual development disorders, and free androgen index. Only articles in Polish and English published after 2010 were included in the study. The authors of numerous articles confirmed that increased levels of sex hormones indeed lead to improvement performance in female subjects and enhance their athletics achievements. Huang and colleagues demonstrated a clear impact of testosterone of muscle mass growth by 4.4% and consequently on strength by 12 to 26% in their 2040 study. Despite it being exogenous testosterone administered to postmenopausal women, in the case of endogenous high testosterone levels, analysis conducted by Bermon and his team, focusing on the International Association of Athletics Federation World Championship in 2011 and 2013, revealed that female athletes with elevated levels of natural testosterone in the highest percentiles not only had an advantage in running events, but also in strength-based competition like hammer throw. where results were shown to be over 7% better. Another study was conducted by Hirschberg and colleagues in 2019, where a double-blind trial was carried out, administering exogenous testosterone and placebo to female athletes once again. To assess the effects after 10 weeks when the hormone concentration in the blood reached approximately 4 nanometers per liter, aerobic performance was measured by running time to exhaustion, revealing an increasing in performance of 21 seconds, corresponding to 8.5% improvement compared to pre-study results. Although information concerning the influence of hyperandrogenism on physical performance by women is limited, some evidence indicate that polycystic ovary syndrome is beneficial in this context. For instance, endurance athletes with polycystic ovary syndrome perform significantly better in the BIP test and exhibit higher maximal oxygen uptake, up to 35%, is approximately 1 liter more during the treadmill exhaustion test than other female athletes with the same body mass index. In sports, success depends on many aspects such as genetics, training, nutrition, and equipment. Conventionally, sports are divided into gender categories, but there is a growing controversy over this division, especially for individuals with personal characteristics that do not fit into the classic gender framework. Testosterone plays a key role in sports performance and gender differences. The control of androgen levels in women is gaining popularity, especially in cases associated with menstrual disorders. Hyperandrogenism in women's sports raises many contradictions and ethical challenges. Sports organizations such as World Athletic and International Olympic Committee have introduced rules regarding acceptable testosterone concentration in women. These decisions were intended to ensure fair competition, but were met with criticism. The discussion of hyperandrogenism in women's sport is complex and requires consideration of many aspects such as medicine, ethics, and gender equality. Thank you for your attention.
Thank you very much for the presentation. Now we will move on to the discussion. Are there any questions in the jury? Are there any questions in the audience? If not, then I will ask a question. What is your each of your contribution to the work?
Thank you for this question. I was working about the data and the presentation. So the research was limited because it's a rare topic of hyperandrogenism in sports in women, but we threw it together. Yeah, that's all.
Okay, thank you very much. We will now move on to the next presentation entitled Metabolic Effects of Deep Brain Stimulation in Parkinson's Disease, Systematic Review and Meta-Analysis by Julia Węgrzynek-Galina.
Unfortunately, Julia was absent in the Katowice today, so my name is Michał Borończyk, and I would like to present you the result of our scientific work entitled The Summary of Knowledge about Metabolic Effects of Deep Brain Stimulation in Parkinson's Disease, Systematic Review and Meta-Analysis. I hope you will find this presentation interesting and inspiring. I would like to start my speech by quoting Henry Bergson's words that the eye sees only what the mind is prepared to comprehend. referring them to my speech, it's important for doctors to see the patient as a whole with all his problems, not only the issue with correlated with the area they're dealing with. For example, for neurologists, it's important to see not only Parkinson's disease, but also metabolic problems. So, deep brain stimulation, DBS, is one of the advanced treatment methods of Parkinson's disease and causes quick and real improvement in motor functions. On the right side, you can see the X-ray of a patient with implanted DBS electrodes. They are put in the patient's brain during the neurosurgery and usually located in the subthalamic nuclei, rarely in the globus pallidus. In the literature, the phenomenon of wave gain after DBS procedure is considered from all over years. And here you can see some topics of such researches. And thus, we decided to comprehensively summarize and synthesize the current knowledge about this topic. The population of our study were patients with Parkinson's disease newly qualified for STN or GPI DBS implantation. In the study, we took into account the body mass before DBS, after that, or body mass changes, and moreover, absolute body mass index, BMI before DBS, after that, or BMI changes. We included studies such as case control study, cross-sectional study, and observational study written in the English language. And in the meta-analysis part of our work, we included research that followed up at least 1 year after the procedure. Here you can see the Prisma diagram with detailed process of selection, qualification, research into analysis. 2 independent researchers searched such databases as Web of Science, Scopus, Embase, and Medline, finding primarily 1,290 records. And after process of screening and assessing for eligibility, there were left 28 articles included in the review part of our work, and 10 of them were included in the meta-analysis. And here you can see the results of the meta-analysis part. At the left side, there is a forest plot of body mass before and after DBS. And as you can see, we proved a significant increase in body mass by mean 6.15 kilograms. And at the right side, the forest plot of BMI before and after DBS. And you can see a significant improvement by 1.87 kilograms per square meter. And here you can see the comparison of BMI and body mass before and after DBS. Please note that both BMI and body mass, in both terms, the distribution and means changed, reaching the higher values 1 year after the procedure. And the reasonable question that should be asked is that where this dependence came from. So there are at least several hypotheses concerning this phenomenon. One of them says about hormones and peptides regulating appetite, and it was proven in the literature that in the DBS patients, there are increased levels of ghrelin hormone, which is a hormone of appetite, and decreased hormone levels of leptin, which is the hormone of satiety. The second hypothesis deals with gastrointestinal functionality and proves that in the DBS patients, the emptying stomach time and the motility of bowels are increased. The third hypothesis pays attention to the location of stimulated brain area, and it seems that both the bilateral localization of electrodes and the subthalamic nuclei localization of the electrodes promotes a wave gain. And last but not least hypothesis tells about physical activity and energy expenditure, and says that if we reduce the patient's symptoms like a tremor, which is the main symptom in Parkinson's disease, it leads to the less energy expenditure, and this energy could be stored and leads to a wave gain. The following conclusions could be drawn from our study, with the most important that DBS procedure contribute to significant wave gain in Parkinson's disease patients. And of course, there are several theses explaining the possible mechanism of this phenomenon. And what would I like you to take away after listening to this presentation is that it's relevant to remember all the side effects of DBS therapy, including the wave gain and other cardiometabolic risk in these patients. Thank you so much for your attention. I'll be delighted to answer any questions you may have.
Thank you very much. Does the jury have any questions? Are there any questions in the audience? Then I'd like to ask a question. What was your personal contribution in the work?
Thank you for that question. This presentation is a part of a huger work we performed about the metabolic effects of DBS, and I was responsible for the part about the glucose and lipid metabolisms after DBS. And of course, I am the author of this presentation, and I take part in the writing the article, which is now under the review.
Thank you very much. Now we will move on to the last presentation of the session, entitled Safety and Efficacy of Local Anesthesia in Facelift Surgery, a Review of Patient Outcomes and Complications by Rohit Gandu-Boina.
Good morning, ladies and gentlemen. Thank you so much. Respected doctors, esteemed members of the jury, unfortunately, the main author is not present with us today, but he'll be watching alongside. My name is Cankutay Mederisoğlu. Today, I'll be your presenter. We did a systematic review on local anesthesia uses in rhytidectomy in facelift procedures. So let's get right to it. I'm genuinely trying. Yes, beautiful. As some of you may know, facelift surgeries has evolved over the past century, and they became sophisticated procedures for facial rejuvenations. Usually different methods were utilized, such as superficial musculoepineuritic system lift or max lift, alongside others, and general anesthesia was utilized while performing them. However, this posed risks and also required really long recovery periods. So, new surgical innovations have enabled the use of local anesthetics. They made facelift surgery more secure, efficient, and they turned them into outpatient procedures. There's also been an increased demand for the same-day procedures from the patient side, so this caused a paradigm shift. According to the data from the American Society of Plastic Surgeons in 2022, over 340,000 patients has gone facial procedures, and out of which over 70,000 were rhytidectomies. Also, another interesting factor, we're going to go back to that in the following stages, but it's usually performed for the patients above the age of 70. Our aim with the study was to explore the use of local anesthetics in facelift surgeries, and we focused on a few key aspects, namely safety, effectiveness, patient outcomes, potential complications, as well as potential management strategies. We wanted to provide a comprehensive understanding of this newly emerging method. Our methodology followed the PRISMA guidelines. We established our records from PubMed, Google Scholar, and Cochrane databases. We removed all the duplicates, and we screened 1,172 records. After that, we implemented our inclusion and exclusion criteria, and we retrieved 38 records. They were assessed for, they were appraised and assessed for quality and validity. For that, we used GBI Critical Appraisal Skills Program, and we narrowed down our articles to 8. We excluded all the articles which were performed under general anesthetics. Also, we did not consider any articles which were performed and published before 1990. Our total publications are 8. They were published between the years of 1999 and 2022. and our sample size consists of 1,943 patients. Their ages, which is the interesting factor, we talked about it previously, usually patients over the age of 70 go under these procedures. However, the data shows, and it indicates that local anesthetic established face-up surgeries are mostly preferred among the younger sites, like among the younger patients, probably because of health reasons, also for the decision from the surgeon side as well. The population was mostly predominantly females. As you can see, most of the authors utilized different local anesthetics. Most of the used one was lidocaine, followed by a combination therapy with lidocaine, ropivacaine, and also bupivacaine, respectively. They used different concentrations, and they used different additives such as epinephrine, sodium bicarbonate, normal saline, and tranexamic acid was also utilized. There were mostly minor complications. They consisted of tinnitus, perioral numbness, metallic taste. Rarely the authors have came across some major complications as well. We'll discuss them in the next section. As you can see, Dr. Ramon faced no complications, which we will also discuss about that because it's really interesting. And Dr. Alaslavi, out of 50 complications, deemed only 2 of them non-tolerable under local anesthesia. One more key aspect, when the doctors decided to use epinephrine, there were few cases of rebound bleeding. These are the total complications under local anesthesia during rhytidectomy procedures. Most of them were minor. However, the major ones can be discussed as hematomas, seromas, emesis, infections. There were few cases of scar revision requirements. However, they were not too much out of all the sample size. Also, one study from Patricio Centurion, one patient had right-sided temporal paresis. However, it was gone by itself in a couple of weeks, so it was resolved. As you can see, the study establishes that there are rare systemic side effects with local anesthetic uses, especially when combination therapies are utilized, such as combining lidocaine with bupivacaine or ropivacaine. Major complications are hematomas and seromas, especially with the additives such as epinephrine. Minor complications, they are less severe, however, they are more frequent, and they were reported 23% and 0.5% respectively from Patricio Centurion and Andrew Kobucha studies. There are some specific complications regarding scar formation, however, they are not too much. As you can see, to conclude, there's a growing preference from patient sites and the surgeon sites for local anesthesia using in the face of surgeries, especially the lidocaine is the primary choice. Rare systemic side effects were noted while they were being administered. We suggest that simplifying mixtures can solve dosing errors. Also, they might minimize toxicity risks. This was the interesting part. Dr. Ramel's study found that they only used lidocaine. However, they used it 3.1 times diluted lidocaine, higher than the recommended local anesthesia dose limits alongside epinephrine, but the peak plasma lidocaine level was 72% below the levels. So, and there were no local anesthesia associated complications, which also indicates that we might need to adjust our dilutions and our concentrations for lidocaine. And role of epinephrine is really important. It might decrease systemic circulatory issues, however, cause rebound bleeding. Another important thing, tranexamic acid was really promising as an agent, which might reduce the bleeding effects, and it warrants further research. Mostly female patients were undergoing face-up surgeries. This was one of our limitations as well. Unfortunately, there's not too many data regarding male patients, so more studies need to be conducted on that. The benefits include the patients can maintain their consciousness. There is no rigidity between head and neck, which makes the surgery more precise because there is no requirement for intubation, which is really nice. Usually, there are a lot of recommended cases of emesis, nausea, and vomiting under general anesthesia. This was prevented. It was rather safe compared to general anesthetic procedures as well. And we recommend personalizing anesthetic doses and making them more simplified to create a guideline for optimizing outcomes and safety is really crucial. And we need to tailor our processes for specific patients, their demographics. It is really important. Thank you for listening.
Thank you very much for the presentation. Now we will move on to the discussion. Are there any questions in the jury? Are there any questions in the audience? Well, then I'll ask, what is your personal contribution to the work?
Yes. Thank you so much. Thank you for the question as well. I helped in data extraction as well as I helped in creating of the presentation. Also, with my friend's help, I created the Prisma chart and we followed the guidelines. And I was also assessing the validity of the papers. Thank you for listening.
Thank you. Any other questions? No. News for me was that the main group of patients that have plastic surgery performed are above 70. I didn't know that prior to this presentation.
Can I add just one more thing? Yeah, they're above 70. However, this study especially revealed that there's a more prevalence among the younger generations, especially with local anesthetic procedures, probably because they're more healthy and they have low risk under local anesthetic procedures and they can tolerate it better. So yeah, that was interesting for me as well. Thank you.
Thank you. All of the submitted papers have been presented, and this concludes the session, and we congratulate all of the presenting authors and participants of the second session of systematic reviews and meta-analyses. Now, I would like to ask the president of the jury for a few words to sum up the session.
Ja bardzo dziękuję za zaproszenie. Dziękuję pozostałym członkom komisji, przede wszystkim Państwu za świetne przygotowanie się do tematu, za zaprezentowanie nam swoich często nowatorskich tematów. Bardzo dobrze się Państwo przygotowaliście, ogrom pracy włożyliście. Ja Wam życzę powodzenia w dalszej pracy naukowej, zarówno przy pracach dotyczących metaanaliz, jak również przy pracach autorskich i również Panom tutaj wielkie podziękowania za sprawne czuwanie nad sesją, że bardzo nam to dobrze poszło. Bardzo dziękuję i jeszcze głos oddaję.
I would like to also thank you so much for your great work. First of all, I would like to say sorry that I was late, but I have other duties. The second sorry is about the amount of questions. I know that they were maybe not so many, but it corresponds with what Dr. Pilarska said. Your work, methodology, scientific level, I'm really shocked, to be honest, because it's on scientific level, not the students level, but it's actually on the really good level. That's I'm really surprised. And I have one request to the organizers, because since we have 4 people in the commission, but 3 of them weren't during the whole session. So I would like to ask if there would be possibility if you only consider Dr. Kaleta Pilarska votes only the results that will be considered for the final decision, which abstract was the best, because I think that would be fair, since only one vote, but what we can do, if all the other people from the jury couldn't be on the all presentations. So I hope so you will accept my suggestion.
We will, of course, discuss it with the organizing committee. Doctors of the jury, thank you very much for these kind words, insights, and work on presentation assessment. Now, we would like to dearly invite you to participate in our workshops, which are taking place right now at the Center for Medical Simulation. And there's also lunch available in the main hall in the main building next to the A3 lecture hall. And on behalf of the Student Scientific Society, I would like to thank you all for participating in the session and wish you a pleasant day. Thank you very much.